Hi everyone, and a warm welcome to the second educational webinar for CNSs and allied healthcare professionals funded by RM Partners. My name's Lorna and I'm the chair this afternoon. I'm the acting lead cancer nurse at Kingston Hospital and also lead the lung cancer nursing team. This month is Breast Cancer Awareness Month and we're very fortunate to have two speakers this afternoon. Unfortunately, Claire Hurley, the clinical nurse specialist from Devon, is unwell, but Nate Hill, RM Partners workforce lead and senior project manager, is going to fill in. But we do have Dr. Niccolo Battisti, a medical oncologist working in breast cancer care at the Royal Marsden Hospital in London, and also Dame Callie Palmer, National Cancer Director for NHS England and Chief Executive of the Royal Marsden NHS Foundation Trust. As we've got two speakers, we're going to take questions after each speaker. So can you please write any questions in the chat, and Elaine, my colleague who's online, will facilitate those questions. A certificate of attendance will be sent to you after the webinar, and please do feedback on the feedback form so that we can adapt these webinars to ensure that we're meeting your needs. So I'm delighted to introduce our first speaker, Dr. Niccolo Battisti, a medical oncologist working as a clinical research fellow in the breast unit of the Royal Marsden Hospital, London. Thank you, Dr. Battisti.
Thank you very much, Lorna, for the kind introduction. I hope you can see my slides. As you said, yes, I'm a medical oncologist. I work as a clinical research fellow in the breast unit at the Royal Marsden. I have an interest not only in breast oncology, but also in geriatric oncology. I am the president-elect of the International Society of Geriatric Oncology, which is a multidisciplinary organization that groups doctors, nurses, and allied health professionals from all over the world with an interest in the care of older people with cancer. And obviously, this is going to be my topic today for discussion. I will give you an overview of what geriatric oncology is about, what are the challenges of managing cancer in older adults, and give you an overview of what we are doing here at the Marsden to address this issue. These are my disclosures. A key important consideration is that obviously in the context of the ongoing demographic changes, we are observing a gradual aging of the general population. This is something that is happening in high, low, and middle countries alike. For example, here on the left, you can see data from the Office for National Statistics that actually in the UK shows that by 2043, we will have 24% of the general population here in the UK age over the age of 65 versus 18% in 2018. And when you looked also at the population of people living with and beyond cancer, the older age group is also the fastest growing segment of this specific group of people. These on the right are data from the SER database in the States. And as you can see here, by 2040, we would expect 73% of cancer survivors to be age 65 plus. Compared with 1975, there's going to be an increase, a 17-fold increase in the age group of 85 plus, a 10-fold increase in the age group of 75 to 84, and a 6-fold increase in the age group of 65 to 74. And this is very common experience in our clinic, that a significant proportion of the person that actually we see and we look after are older. What we also know here in the UK is that survival outcomes in this age group are different compared with other countries. Again, these are data from an analysis called EuroCare that was conducted a few years ago based on cancer registry data on more than 10 million people living with cancer. And here in this graph, you see what are the age-specific survival rates at 5 years for people registered to have a cancer diagnosis in this National Cancer Registry. And as you can see here, obviously there is a decline in the survival rates with increasing age, but there is also quite a significant gap in within the older patient population. For example, here 75 plus, between, for example, countries like the UK and Ireland and Southern Europe. So this is something that, again, we need to understand and address with specific interventions and cancer policy level, but also in our everyday clinics. One of the key challenges in geriatric oncology is that there are significant gaps of knowledge in how we should best manage cancer in older individuals. We know this since 1999, when an epidemiologist, Laura Hutchins, demonstrated that among the participants to the Southwestern Oncology Group, so a big research group in the States, among those trial participants, only 25% were age over 65, whereas at that time, 63% of the cancer patient population, again in the States, were of that specific age group. And this really suggests that the evidence that we are using to inform our anti-cancer treatment decisions for this specific population of patients may be a bit more limited and less easy to apply in routine practice. For example, if you look at the trials addressing breast cancer, there was even a more striking gap, 49% versus 9% at that stage. But obviously, in the meantime, plenty of things have happened, plenty of new treatments and innovations. But somebody else, Arthur Ria, again, who was leading figures in the geriatric oncology field and past SIOC president, conducted another analysis 15 years later on studies that had been sponsored by the National Cancer Institute in the States, so addressing more contemporary treatment regimens. And again, for example, even in that case, she found that at that stage, only 10% of the patients recruited to those clinical trials were aged 75 plus, where at that stage, 28% of the general US cancer patient population were in that very same group. This obviously leads also to some variation in how we manage cancer in older individuals that may be partially related to case mix, so simply to the fact that we are seeing different people in our clinics, but may also be related to these specific problems. Here in the UK, there is a big observational clinical trial called Bridging the Age Gap that recruited women over the age of 70 with operable breast cancer between 2013 and 2018 in 56 breast units in England and Wales. And it was very interesting to see here on the left that even when we select patients based on fitness or based on their overall health and based on their risk, the breast cancer risk of recurrence, even in fit women with high risk breast cancer, only less than 1/3 of these patients actually did receive chemotherapy within that study. Again, this was an observational study, so women were recruited within the study and they were managed according to standard and local practice. But still, those patients that we would deem most likely to benefit from, for example, using chemotherapy for curable breast cancer because they're fit and because they're high risk, only a minority of these women did receive chemotherapy. On the right, you can see another very interesting analysis that we conducted here in the UK. This was an analysis led by Dr. Janine Mansi at Guy's Hospital on almost 50,000 patients with stage 2 to 3 breast cancer based on SACT data, so registry data on the use of systemic anti-cancer treatment. And in this analysis, we looked at rates of use of systemic anti-cancer treatment in this patient population. In these two graphs, you have on the x-axis the number of patients seen by each trust, which is represented by each circle. And on the y-axis, you have the rates of use of systemic anti-cancer treatment in each trust. And as you can see here, there is obviously a significant drop in the use of systemic anti-cancer treatment in the older age group, 70 plus versus younger than 69. But there is also increased variation in the use of systemic anti-cancer treatment in the older age group versus the younger age group. And this is despite adjusting for case mix, so adjusting for characteristics that pertain to the fitness, the overall health of these patients. When we looked at specifically patients with higher risk breast cancer, so ER-negative breast cancer, so not estrogen-driven, those that we would typically feel much more inclined to use chemotherapy for, again, this significant gap persisted, with 33% of the older patients receiving chemo or general systemic anti-cancer treatment versus 92% in the younger age group. But why it is so complex to manage cancer in older patients? There is obviously a lot that these analyses are not capturing, which is essentially the overall health of these patients. In the older age group, we obviously see a gradual decline in the functional number of organs and systems, but we also have to deal frequently with the higher burden of comorbidities, of lack of social support, polypharmacy, psychological distress, malnutrition, cognitive impairments, impaired function, that really make increasingly difficult to treat these patients with effective and safe treatment options. In the context of these problems, the focus should increasingly be quality of life of our patients over quantity of life. Also because obviously the life expectancy of these patients may be more limited, and this might mitigate what the benefit that we would expect on standard treatments in a younger and fitter patient population. So there is a significant risk of under-treating, but also over-treating older patients with cancer. The solution to this is using what we called comprehensive geriatric assessment, so integrated oncogeriatric care, which is something that we have learned over the last 2 decades, really, from our geriatrician colleagues. And it's something that they are routinely doing for their patients. CGA is a diagnostic and therapeutic process looking at domains that are crucial to the well-being of older people. And these are obviously comorbidities, burden of ongoing medications, functional status, cognition, mood, nutrition, fatigue, geriatric syndromes, with a number of validated tools that we can apply and use in the clinic to determine what is the overall health of that person and to better inform anti-cancer treatment decisions. And crucially, this is something that should happen under the care of a multidisciplinary team that includes not only doctors, including obviously medical and radiation oncologists, surgeons, and geriatricians where available, but crucially also nurses and allied care professionals, pharmacists, supportive care specialists, primary care, and psychologists. And the key aspect of CGA is also to link this to personalized interventions that may not simply lead to adapting anti-cancer treatment plans where required, but also tackling a number of additional problems that the patient may have beyond the cancer. And again, for example, functional impairment with strength and balance training, use of devices, home exercise programs, fall prevention, and so on. Comorbidities with closer involvement of caregivers and primary practice, cognitive impairment, with, for example, delirium prevention and management, limiting the complexity of treatment, thorough medication review, which is also very important to address the issue of polypharmacy in this age group. Psychological problems with counseling, CBT, pharmacological therapy, support programs, and so on. Nutritional problems with nutrition counseling, specific dietary recommendation, oral care supplements, social support with the help of nursing and home health, assistance with transportation, management of caregiver, home safety evaluations, and support groups. This is a unique opportunity really to aim for personalized care for this specific patient population. And there are increasingly a number of benefits that we can achieve if we integrate oncogeriatric care in the routine management of older people with cancer. Historically, we have learned from a number of clinical trials that actually integrated oncogeriatric care can allow us to be much better in predicting the prognosis and the risk of complications and side effects from whatever anti-cancer treatment. We can shift impact on treatment decisions. We can find problems that are sometimes a bit more difficult to find out from routine assessment. But last year, 4 randomized clinical trials reported a big oncology conference called ASCO. And these trials actually looked also at impact on other endpoints that usually oncologists like me feel much more attractive. And these endpoints are the risk of systemic treatment toxicity, unplanned hospitalizations, again on systemic treatment, early treatment discontinuations, quality of life, completion of advanced directives, and for patients undergoing surgery, postoperative inpatient stay, and ICU admissions. A very important and attractive aspect of comprehensive genetic assessment is that it allows me also to estimate what is the potential risk of severe toxicity in this patient population when they are being considered for chemotherapy. And this obviously allows me to enhance the discussion that I can have with my patients to really balance what are the potential benefits that we are looking at with that specific treatment option, but also what is the potential risk of side effects, severe side effects. And we have a number of tools that are essentially derived from various geriatric assessments that we call chemotherapy toxicity prediction tools that we can use routinely in our clinic. As you can see, this is one of these called the Cancer and Aging Research Group tool, which were validated a few years ago by Arthur Ria in a population of patients, of older patients, age 65 plus with cancer, initiating a new line of systemic treatment. And as you can see, these tools include the consideration on what is the chronological age of that patient, what is the type of cancer that is being that requires treatment, what is the chemotherapy dose, whether we are aiming for a dose reduction up front or not, whether we are considering a single agent chemotherapy or a polychemotherapy, lab values, hemoglobin, creatinine clearance, geriatric assessments and consideration like hearing loss, number of falls over the last 6 months, functional status, and social activity support. And with this tool, I can estimate what is the risk of that person dealing with severe, so grade 3 plus toxicities. So toxicities requiring hospital admissions. And as you can see here, the investigators also compared the performance of this tool with something that we use far more frequently, like performance status, in this case, Karnofsky performance status. And they demonstrated that this tool is much more accurate in predicting the risk of toxicity in this patient population, whereas with performance status, there is absolutely a less clear trend in the rate of toxicity. And this is just to give you a quick overview about those 4 clinical trials that I mentioned that reported last year and really got the geriatric oncology community very excited. Here, these are the 2 studies that actually looked at impact on the risk of severe toxicities on systemic anti-cancer treatment. GAP70 on the left recruited patients with stage 3 to 4 incurable cancer over the age of 70, initiating a new line of systemic anti-cancer treatment in more than 40 community oncology practices in the States. These were more than 700 patients that were randomized to a geriatric assessment intervention arm versus standard care, what we are doing now. And perhaps not surprisingly, patients randomized to a geriatric assessment-driven set of interventions had lower rates of overall hematological and non-hematological toxicity, which is likely to be explained by the fact that oncologists actually were more wary of using upfront dose reductions a bit more frequently. But the investigators looked also at survival outcome at 6 months in this, again, population of patients with incurable cancer did not show any impact on survival outcome at 6 months. On the right, the GAIN study addressed a very similar question, but in a population of patients aged over 65 with solid tumors initiating a new line of chemo, but also with curable cancer. And again, with a very similar trial design, randomized patients to an oncogeriatric care versus standard care. And again, those patients that were randomized to oncogeriatric care had lower rates of toxicity. This study also looked at completion of advanced directives, and perhaps not surprisingly, again, patients randomized to the geriatric assessment intervention arm had higher uptake of advanced directive completion. This study was published on JAMA Oncology literally 7-10 days ago. Quality of life is another crucial endpoint, obviously, in the context of a more limited life expectancy. And this endpoint was evaluated by the Integrate study, the third study that reported last year, that essentially randomized again patients with solid tumors and aggressive types of lymphoma over the age of 70, initiating a new line systemic treatment in 3 general hospitals in Melbourne, Australia. 154 patients were again randomized to an oncogeriatric arm versus standard care, and again, perhaps not surprisingly, did show better quality of life outcomes for patients randomized to an oncogeriatric approach. Quality of life was evaluated within this ELFI score, which is derived from the EOTC C30 questionnaire. And finally, again, the same study, Integrate, looked also at impact on hospitalizations, because we can actually envision also making this model more sustainable if we prevent hospital admissions in this patient population. And that study indeed did demonstrate that patients randomized to non-congenital approach had less frequent emergency presentation to A&E, unplanned hospital admissions, unplanned hospital overnight bed days, and also lower rates of early treatment discontinuation due to side effects. The study on the right is the fourth study, the surgical study, that recruited patients with GI malignancies being considered for surgery above the age of 65. These patients were recruited in Boston and Massachusetts General Hospital. And again, those randomized to an oncogeriatric approach had shorter postoperative inpatient stay and lower rates of intensive care unit use. Crucially, this is something that guidelines are increasingly recommended that we do in routine practice. The American Society of Clinical Oncology guidelines that as oncology regard as very important guidelines to inform our daily practice recommend that we do geriatric assessment for all patients over the age of 65 when we are considering them for chemotherapy. And this yellow box shows you what is the minimum data set that we should actually investigate when considering these patients for chemo. Again, we should use chemotherapy toxicity prediction tool. We should look at what is the individual life expectancy of that person if she or he did not have any cancer. We have some specific tools that we can also access online to determine that. What is the functional status of that person? What is the burden of comorbidities? Did they have any falls over the last few months? Do they have depression? Do they have cognitive impairment? Are they malnourished? Obviously, SIO guidelines also recommend geriatric assessment in this patient population, and interestingly also the use of screening tools that we can use to identify who are those patients that actually do require full CGA, which is a much more time-consuming process. And then NCCN guidelines as well, the National Comprehensive Cancer Network guidelines. They publish every year specific guidelines for the management of all the adults with cancer. These models of care are also a unique opportunity to improve the recruitment of all the patients to clinical trials and expand the evidence base that should inform the management. As I mentioned, older patients, they tend to be underrepresented in clinical trials, and that's also because sometimes endpoints are less meaningful for them. They're sometimes very much focused on survival benefits, but less on quality of life, impacts on physical function, impacts on treatment tolerability, which are far more important in this age group. And again, if we implement these models of care, we can actually probably also better select patients, even in this age group, that are absolutely suitable for those clinical trials, and maybe come up with new dedicated trials to that will inform in the future the management of maybe more vulnerable and frailer patients. And another key aspect to bear in mind is also that these models of care offer a unique opportunity to provide and expand the scope for more training and education of the cancer workforce. As a medical oncologist, I had to proactively seek a bit of training in geriatrics aspects, but I'm sure that this is a concern for many other professions. This was an analysis that a geriatrician that leads the Gold Service, the Guy's Hospital, conducted a few years ago in oncology trainees here in the UK, showing that actually there is quite a big unmet need in the requirement for training in these aspects, also for, again, oncology trainees, that actually are going to see a significant proportion of all the patients when they graduate as oncologists. A key challenge is how do you implement these models of care in routine practice? Bear in mind that the algorithm should always be the same and use essentially some tools that we call geriatric screening to identify who are those patients that require enhanced care, so an oncogeriatric approach, versus who are those patients that actually do need to see just the oncology team. Essentially, if you look at the literature, three main models have been codified. A consultative model, where you have essentially an oncology team that refer patients to a geriatrics team for geriatrics workup, and then is in charge of the cancer management of that patient once the health of that person has been optimized by the geriatrics team. A shared care model, where you actually have an oncology team and the geriatrics team sharing the care of that person throughout the whole treatment pathway. And a comprehensive model, which is usually the most appropriate model where a geriatrician is not available, such as, for example, cancer centers, where you set up a multidisciplinary dedicated team, a geriatric oncology team, that is in charge of the management of that patient throughout the whole treatment pathway. If you look at what's happening internationally, there are very mature geriatric oncology programs, especially in North America, US and Canada. You have actually also oncologists being dually trained in oncology, hematology, and geriatrics with dedicated training fellowships. Here in Europe, France is definitely paving the way. The National Cancer Plan in France has been funding the creation, the development of geriatric oncology units throughout the whole country since 2006. And there are additional programs, clinics, units also in other countries. For example, here in the UK, the Gold Service. But there are a number of other dedicated programs that are now popping up also in other areas of the world, in Asia, in Oceania, and in South America, because this is increasingly a problem that as clinicians and as from a cancer policy point of view, we will need to deal with. There are a number of stakeholders, so obviously internationally, professional society like SIOG, obviously the European Society of Medical Oncology, ASCO, research groups that are very interested in these aspects, CARG and the OTC, for example, here in Europe. And what we are now trying to do here at the Marsden is really to develop a new model of care, a new team that will be looking after our older patients with cancer in our hospital. We are calling it Senior Adult Oncology Program, and we have now recruited, with the support of our trust and our Cancer Alliance Southern partners, a first core of this MDT, which includes an advanced nurse practitioner, a physiotherapist, an occupational therapist, a dietitian, and a pharmacist that will essentially be able to review our patients in our clinics if they need to. And we will use a tool which is called SOP3, which is a geriatric screening tool that has been used for a very long time in other centers to determine who are those patients that do require CGA and an integrated oncogeriatric treatment plans to adapt when needed cancer management, but also to address any other needs that they may have. We're going to start from the 1st of November, and we're going to integrate this care model in our breast unit medical oncology clinics at the Sutton site. We will run this model for 12 months and then gradually expand it to additional tumor types and pathways, for example, also the surgical pathway. And hopefully, the dream is to really get to this stage where you have an MDT that will really manage these patients collaboratively and holistically, and everybody will have obviously equal voice to determine, what is the best course of action for each individual patient. This is a very nice paper that my mentor, Martin Exterman, that leads the genetic oncology program at Moffitt in Tampa, published early this year on Lancet Oncology, that really depicts what are the key priorities you want to advance the care of all the patients with cancer globally. It's all about education, obviously, as I mentioned, integrating geriatric oncology into the medical nursing and AHP training programs, but also raising awareness in the general public, improving clinical practice, so again, developing models of care addressing the needs of this patient population to try and limit as much as possible the risk of undertreatment and overtreatment, developing specific guidelines and recommendations based on the evidence available, and establishing center of excellence in geriatric oncology, which is obviously what we are trying to achieve here. And research, expand the evidence base for the management of cancer in older adults by coming up with clinical trials that are meaningful for them, and maybe also using technologies to, again, meet more easily their needs. This is my final slide. This is a slide that I borrowed from my mentor, Dr. Exterman, that really depicts what I love about geriatric oncology, which is really the opportunity to integrate disease-specific considerations on, for example, a number of biomarkers now we are using to inform our systemic anti-cancer treatment decisions in these patients, along with more detailed, more precise assessments regarding the patients, the person that we have in the clinic, that go beyond simply just looking at ECOG or WHO or Karnofsky performance status and chronological age, but really a deeper understanding of what is the overall health of that person, what is the life expectancy, what is the organ function, functional reserve, social support in the context of their preferences, and really integrate them with the cancer-specific consideration to come up with an integrated plan. These are some resources that I wanted just to highlight. If you are interested to learn more about the field of geriatric oncology, our website, SIOG, the Cancer and Aging Research Group, the Moffitt Cancer Center website, you can find all these tools that are freely available for your use in the clinic. There is JGO, which is a specific publication dedicated to this topic. I would just like to acknowledge the support, the fantastic support of all these people that have been involved in the development of our senior adult oncology program in our hospital, and invite you to our next conference, which will take place online, obviously, in a few weeks, 4th and 5th of November. And thank you very much for your attention. I'm very happy to take your questions.
Wow, thank you so much. That's amazing. Elaine, shall I go over to you? Are there any questions?
There are, but actually, in the interest of time, Nicolo, I think you've answered them. The questions have been around cancer and older people education in undergraduate, and I think that as that question came through, you addressed that in your slides. So it's much needed, both older person and cancer, of course. So thank you so much. I'll hand back to Lorna. Thank you.
Thank you for having me.
Thank you so much. Thank you. Now, I'm very, very delighted to tell you that Claire Hurley, the clinical nurse specialist in Devon, has joined us despite being unwell. So thank you so much, Claire. So Claire and her team won a British Journal of Nursing Oncology Team of the Year award for their innovation in redesigning the diagnostic pathway in the context of workforce challenges. And I think Claire's going to be reflecting on the nurse-led recovery package in rural breast cancer. Brilliant. Thank you so much, Claire. I'll hand over to you. Thank you.
I wanted to talk about implementing a nurse-led recovery package for breast cancer patients in a rural symptomatic unit. So we live in Devon, and we are a district hospital. We're a breast care team based in a trust that NHS England have actually identified as unavoidably small due to our remoteness. So although our team is small, our ambition is to provide best practice and equity for our patients diagnosed with breast cancer. So this includes offering an appropriate stratified nurse-led recovery package with open access availability that enhances the patient's breast cancer follow-up journey, and then both benefits primary and secondary care. So as a team, we've got a history of innovation and adaptability, partly due to our size, but also partly due from a culture of necessity. So the part of the recovery package that we were struggling to introduce was the treatment summary. So a remote tracker system wasn't available, and appropriate skills within the team to carry out the summaries and offer open access assessment clinics were limited. The consultant-led follow-up clinics were oversubscribed and often running sometimes months behind. So this led to increased patient frustration, anxiety, and distress. So the main objective of the cancer reform strategy from the Department of Health in 2007 was that in the UK was to establish a national survivorship initiative. And this was then launched in January 2010 by the Department of Health and Macmillan. So it set out that to ensure that those living with and beyond cancer get the care and support that they need to lead a healthy and active life as possible for as long as possible. So the recovery package was introduced with 4 main components. So the first component was the holistic needs assessment and care planning. The second part was the treatment summary, completed at key phases of the patient's journey and shared with the patient's GP practice. A cancer review completed in general practice, and an education and support event. So they should all run alongside stratified care pathways, which actually help to individualise follow-up care, be it self-supported with rapid access back into the specialist team, or continued face-to-face with a healthcare professional, which is often an oncologist. So the breast care team were the first team at our trust to introduce 6 monthly moving forward events, which covers topics such as diet and exercise, consequences of treatment, and what to look out for in the future, with information about lymphedema and menopausal symptoms, which all breast care CNSs are involved in presenting. So alongside this, we had been offering health needs assessments at 6 weeks following diagnosis. And then if it was identified at that point as requiring more support, they were then offered a further follow-up at 6 months' time. We used the Macmillan electronic health needs system, which has helped us to formalize this. So we've implemented this over the last 2 years. And so to determine the most important feedback, we did send out patient satisfaction questionnaires, and we conducted an audit. And we had a great response to that, sort of saying that patients found it really useful. So on average, there were 2 consultant-led follow-up clinics a week, and this was just becoming unsustainable and having an impact on then the 2-week wait triple assessment clinics. So implementing the nurse-led treatment summary meant that the service could remain viable and almost immediately cut down a minimum of 8 consultant-led clinics to a maximum of 2 follow-up clinics a month. So implementation was only possible with a collaboration of the MDT. Leading the change for practice was only possible because the MDT was core 8, supportive and cohesive. If this nurse-led end of treatment clinic had not been introduced to replace the 5-year follow-up of consultant-led clinics, then the potential of being overwhelmed as a breast team was very real. The main reason for regular face-to-face follow-up after breast surgery was to monitor for local recurrence, manage late effects of treatment, and provide information. So as an MDT, we discussed how we could achieve this switch in practice. So it involved writing and agreeing SOPs after patient pathway had been agreed. The MDT would ultimately decide who would require ongoing face-to-face follow-up, and this usually involves those patients requiring chemotherapy or diagnosed with a metastatic disease. It was recognised that we would require new radiological documentation, which would allow practitioners to order 5 consecutive annual mammograms. And due to the patients not having a clinical review, a patient questionnaire was also implemented for them to complete at their mammogram appointments. So the CNS team identified the additional knowledge and skills training that they would require to support this change to a nurse-led service. So this included completed a physical assessment and clinical reasoning module, non-medical prescribing, and IRMA training to enable us to request breast imaging so that the open access part of this recovery package could be run. So the documentation we use is adapted from the Somerset Cancer Register. So the patients have a 45-minute face-to-face appointment. Obviously, during COVID, we still did this, but we did it via telephone. We discuss all aspects, so including future follow-up arrangements such as their mammograms, how to get back into the system, and a physical examination when it's face-to-face. As our numbers are small, we hold the information on a spreadsheet until a tracker system is available. And our trust is soon going to be implementing the MyCare system. So hopefully then we will have access to some sort of tracker. So once completed, the end of treatment summaries are shared with the GP and a copy goes to the patient for reference. This information helps the patient then go forward with self-supported management, and that, along with their health needs assessments, helps to inform and signpost them to various supportive resources, including referral to counselling, support groups, and our Moving Forward event that we run, which then also gives them an opportunity to meet with other people who have also gone through the same process. And at the moment, we're still doing these virtually due to COVID. So that is it in a nutshell.
That is brilliant. Thank you so much, Claire. And I'm sure that if you're able to share that, your slide, I'm sure there'll be lots of people who would like to look at that, if that's okay. Elaine, is there any questions for Claire?
There is a couple come through. I mean, obviously, I'm delighted that our National Cancer Director can hear you talking about this award-winning service, and you've had a unique response to something that was very unique in your area, haven't you? Did you get any resistance from anybody in terms of how it was to be run?
No, absolutely not. We had support from everybody within the MDT. It was just fantastic, and it was something that needed doing, and we had to find a way of changing it. And with the national guidance out there, we just knew we had to just get on with it.
Yeah. Any resistance from any of the nurses?
No.
Yeah.
No. Do you know what? I work with such an amazing team, and we've worked together for over 10 years, and we are, absolutely not. We all roll with the times and do what needs to be done for our patients.
Okay. And so what's next for your service?
Oh, well, I want to get some nipple tattooing because we can't do that at our trust at the moment. So I want to get that introduced, and maybe some more reconstruction. The sky's the limit. Who knows?
Yeah. Thank you so much, Claire. Thanks, Lorna.
Thank you.
Thank you, Claire. It's brilliant. And lastly, it's my pleasure to welcome Dame Callie Palmer, National Cancer Director for NHS England and Chief Executive of the Royal Marsden NHS Foundation Trust. Thank you so much, Callie.
Thanks, Lorna, and many thanks to Elaine for inviting me. And great to talk to you all this afternoon. I think I've got 10 to 15 minutes, so I'll race through. Just as Lorna said, I've got a dual role, sort of roughly 50-50 between being Chief Executive of the Royal Marsden and since 2015, National Cancer Director for NHS England. And it started in that national role as development of national strategy for improving survival and patient experience, turned into pandemic management, recovery and restoration. And it's, as the previous speaker said, it's been an interesting time, really. And in many ways, I was just reflecting on breast cancer relative to some of the other things we're trying to improve in cancer. And in many ways, breast cancer is the model we're trying to follow in other cancers. So essentially, the long-term plan for cancer to save lives and improve the whole patient experience is really built around early, fast diagnosis, better patient experience, and innovation. So we just heard a service model innovation, which makes a difference. And in cancer, we're fortunate to have such a specialist workforce and the ability to innovate to make things different for patients. But what we've really seen during the pandemic is a big reduction in people coming forward. So there are around 40,000 people who are what we call the missing first treatments. They're people who just haven't come forward, and we know would ordinarily have come forward, principally for surgery. But we've got to restore and recover and give people the confidence to come forward. Then, of course, we've got a sort of building group of long waiters. Breast cancer is interesting because when we look at how we do relative to other countries internationally, of course, breast cancer is one of the areas where the NHS does really well, and that's to do with the screening programme, the one-stop shop model, the stratified follow-up, which was trialled in breast cancer, and we're trying to roll out to other cancers. And so it's a sort of model where we need to carry on improving, but actually it's the poster child, if you like, for some of the other cancers where we're trying to follow that model. I mean, generally, as you all know, survival in breast cancer has been improving, and there was there's been an improvement in 5 years survival over the last 10 years or so, 3 percentage points. So we're seeing a general increase in survival across all cancers, including breast cancer, but we need to keep improving and ironing out variation and really managing the full restoration of services. And breast cancer has been particularly hit by the pause in the screening programme. So I'm working with screening colleagues nationally to try and make sure we can turn that back on efficiently. So breast cancer is a great model, has been challenging during the pandemic, as it has for all of you, so for patients and for staff. But we did manage to, with your huge hard work, so nationally breast cancer referrals were maintained at 98% of pre-pandemic levels. That, of course, masks individual experience for individual patients, which was difficult, and the variation in practice across the country, which was difficult, but really maintained referrals at quite a high level. And then in some of the sort of pathway challenges, in July, 2-week wait performance improved to 81% from 67% in April, so moving in the right direction. London's experienced many of the same pressures as the rest of the country during the pandemic. But screening coverage in London's historically been lower than in other parts of the country, and it's really important to try and improve uptake and work with our screening colleagues to really improve sort of screening uptake, case finding, and then speed through to early and fast diagnosis. And we've rolled out, it sounds like a big figure, but it isn't really nationally, but 22 million has gone out for replacement mobile breast screening units, and 50 million to increase capacity and activity. So we know where we need to target the resource to try and improve performance. So alongside the screening programme, the other thing we're trying to do obviously is carry on instilling public confidence and get people to do their self-exams and raise awareness. So all the work that you're doing, we're trying to help also nationally with doing that. You've probably seen some of our national media campaigns, the sort of Help Us to Help You campaign. We haven't really focused on breast in that at the moment because it's doing comparatively well. We have been focusing on lung cancer, where people haven't been coming forward because of the crossover with COVID symptoms, and things like colorectal cancer. So we've been focusing national campaigns and working with some of the cancer charities to get them to help us get messages out to the public about signs and symptoms and confidence in coming forward. And you'll have heard, as I have, you know, people's concerns about bothering the GP, B, being able to get face-to-face appointments, and C, then coming forward into the system in a timely manner. So that's all been, that's all sort of work in progress. But raising awareness is a job for all of us, I think. But I'm very grateful for the work that you all do in your own teams and areas to try and improve that. So some of the work that we're doing in the national programme, then I'll relate it again back to breast cancer. So we've and then we talk a little bit about workforce, because that's sort of at the front and centre of all our work to try and improve survival and patient experience. So we've rolled out just recently 20 million through our cancer alliances nationally. And the reason we've done that is to look at how we streamline the front end of the pathway. If you look at all the work that the NHS has done over time in cancer, various national cancer strategies, it's mainly about the treatment bit of the pathway. It's been less about efficient case finding and early fast diagnosis. So big emphasis on the front end of the pathway. And the 20 million is about helping people trial new models. So lumps and bumps clinics, cancer hotlines serviced by cancer professionals so that people can get access to professional advice quickly, support workers and patient navigators. So it's how we can invest in workforce to support all of you. So to support nursing and AHP colleagues effectively, so you do the bits that you have to do as the specialists, and we support you with different models and different roles. So I think that's incredibly important. And of course, as you know, and as I reflect, most patients' experience is actually built on the work of nursing and AHP. There'll be touch points with a consultant, surgeon or oncologist, but actually most of the experience people have is with all of you. So that is incredibly important, that the workforce is resilient and that we support you in whatever way we can. So we've rolled out this 20 million for restoration and recovery. That's to help triage management of referrals. We've seen record numbers of referrals coming through on the urgent pathway, well above the sort of 100%, so way beyond pre-pandemic levels. The issue is trying to manage all that efficiently as people come through for treatment. But we've seen record levels, in fact, the highest level ever of urgent referrals across all cancers in March this year, as people started to have the confidence to return and come back through for assessment and diagnosis. Trying to get to a system where we have whole pathway navigation. We work across organisational boundaries, because cancer doesn't work in neat hospital boundaries. And the role of patient navigators and whole pathway navigators, I think, will continue to be important, and we're trying to support the funding of those. And each patient referred to these rapid diagnostic pathways that we've been rolling out across the country, built originally on the breast model, the one-stop model, which, and as close to that as possible. It doesn't work in all cancers, but these rapid diagnostic pathways, the idea behind it is to make sure we have a dedicated patient navigator to help patients navigate that system efficiently. So big emphasis on the front end of the pathway, built on the breast experience and the breast model. And we're trying to use different types of roles to support the work of you as the specialist cancer workforce. And the aim with the rapid diagnostic pathways is quite simple. It's just basically to make sure that every patient gets the right tests at the right time in the right place with as few visits as possible. And we're aligning that with this new model of community diagnostic centres, which will provide some additional capacity, provided we've got the workforce in place to support that sort of community-based diagnostic journey. The other thing that's been happening, including for breast cancer, is to try and really accelerate the rollout of new drugs and new treatments. So whether it's shortening radiotherapy regimes or cancer drugs that can be delivered orally, we're trying to do that to reduce risk and footfall to hospitals. So quite a lot of that's gone on during the pandemic, including, I'll get the pronunciation wrong, so someone can correct me, Phesgo for people with HER2 positive breast cancer. So lots of work. So the upside and all the downside of the pandemic, I think, has really been an acceleration of some of that innovative work, both the type of treatment, the radiotherapy fractionation regime, and the models and the patient navigation. I was just going to talk a little bit about workforce, because I think that's kind of crucial. And as I said earlier, sort of front and centre to all the work that you and we in the national team do. And just to say, and just to say, I'm working really hard with Health Education England and the government to really build capacity in the cancer workforce, and that's particularly around the CNS workforce, radiographers, and diagnostic professions, because if you work on the principle of trying to manage the front end of the pathway and then manage patient experience with all those touch points working well, that really is about nursing and AHPs as much as anybody. So hopefully some of you have spotted it, but there are a number of training opportunities for people who want or are aspiring CNSs to go through a training program funded by HEE. They've told me that they've got just over 1,200 training opportunities to existing and aspiring CNSs to try and develop capacity in the NHS for master's level or advanced training and education. And then there are a further 250 CNS training grants for this year. So those are being offered this year. And then we're investing, again, additional money to try and cope with mammography workforce shortages and increase training capacity through the National Breast Imaging Academy. So it's trying to find ways where we know a pressed workforce, there are other ways in which we can help train, develop and provide different professional support. And then the development of the mammography associates. So that's the other sort of key work that HE have been supporting with. So lots of work still to do to get us to our ambition in 2028 to move from just over half of people being diagnosed at stage 1 or stage 2 of their disease to 75%. And that's about saving 55,000 more lives a year, or people surviving for 5 years or more every year if we get to that ambition of much earlier, faster diagnosis. So breast cancer continues to be a really important pathway and model for us for other cancers, and we need to continue to support all these sort of innovative models that we heard about already in breast cancer to try and improve the experience of patients and further improve survival. And just, making sure that personalised stratified follow-up is supported and rolled out evenly across the country, things like that. Also, we need to just make sure that happens effectively countrywide rather than just in pockets of activity. So finally, I just want to say thank you very much to everyone for the phenomenal work that's been going on, particularly over the last 18 months, which I know has been incredibly difficult. But to keep cancer services going, and particularly breast cancer services going, sort of referrals going at 98% of pre-pandemic levels is fantastic. Shows that people have confidence in coming forward, and that's to do with the confidence that the workforce, the breast cancer workforce, instills in them. So big thank you with my local and especially my national hat to all of you for the work you've been doing always, but particularly throughout the last 18 months. Elaine and Lorna, I'm going to pause there, but happy to take any questions. I've gone at speed, but I hope some of that has some resonance for you.
Thank you. I had a question myself, actually, around, as you know, I'm sure that Macmillan put a paper together recently about we're going to be 4,000 nurses short by the year 2030, cancer nurses short. And I'm really, really encouraged to hear about a training programme for clinical nurse specialists, because it's been surely lacking for many, many years. And we all need to put our hands up to that, as why it's taken so long to get there. My question really is about workload, actually, as we're victims of our own success often. You know about the advances in melanoma and lung cancer even, and in all the cancers, actually, well, the majority. We've never actually got to a ratio. We've tried many times, how many clinical nurse specialists, which we know are really important to patients, do you need whole-time equivalents per, say, 100 new referrals of breast cancer, or maybe it's 70 new referrals of lung cancer, because the mix of cancers is different, isn't it? We've never got there. We tried. I know I've worked with Macmillan to try and get there. But what happens is, of course, as the numbers go up, the workforce doesn't keep up with that demand and that activity. Who should we be working with to get that sort of ratio? I mean, is it the national team? Is it HEE? Is it the alliances? Is it, who is it? Or is it the wrong metric?
Well, so I think that there's two. We have to be pragmatic about the workforce, and so this is a moment in time when people are tired, resilience is not high and people are leaving or deciding to do the other thing. I'm worried locally about nursing staff here, or Australian or from the Philippines, actually going and staying because they've had enough. And I'm sure, maybe that's a London problem a bit, but, so I think we have, so before I come back to who on ratios, the first thing I want to say is we've got to be pragmatic. And I think it's a mixture of making sure we operate much more productively. We all know where we're not that productive, okay? That's not to say people don't work incredibly hard, because they do, but I can spot, as you will be able to spot, areas of the pathway management, multiple testing when patients don't need a multiple test. We can see things that aren't working optimally. So I think there's a big need, and in cancer, it's good because you've got great data to say where can we do things more efficiently. And I think there's big gains to be had in productivity. So there's a job for all of us in that. I do think there's also an investment ask, which is why the national team have been pressing Health Education England and the Treasury to prioritise nursing, radiography, and there's 7 professions in cancer we've been pushing to get investment in. So I think it's a mixture of investment and productivity improvement. That's the first thing to say. In terms of the ratio, so in terms of ratios, I think the unit of planning for the new ICSs will be the Cancer Alliances. So they will work across organisational boundaries for their ICS to say where the investment needs to come from. What are the priorities for the service? What are the priorities for investment? So I think the Cancer Alliance as a unit is going to be increasingly important. And providers like the Marsden, we host RM partners as UCLH do in another part of town, for example. So we feed into that, but I think the Alliance can look at what the need is across a whole geography and where the priority investment should be, both in workforce and in the service itself. So I think the Alliance is an important model. Then the job for the national team with HEE is to continue to hammer home what we need to create some of this benefit for the long-term plan for cancer. And it is about more CNS places and, more support for radiographers, for example. So, and how much investment we can get. And where we got to is quite a good place, I think. So, and we're waiting to hear further. And we've said what we need is a multi-year funding plan. Being told, it's great that we got a 1-year settlement on CNS training places, but my push is we need to see that over time, because this is, there are lead-in times to do this well. And then it's building things like chemotherapy support workers, patient navigators, to take the load off all of you, so you can do what only you can do, and we can support you with some of those other functions. And I think there's a lot of gain to be had in that. We're not going to magically double the number of CNSs in the NHS. It's not going to happen. So what else do we do to try and improve that? Because it's really important. And Macmillan and we are all together on that, and they work with me on the National Cancer Board. And there's no, you can't put anything between us on that. We're together on the importance of getting that right.
Yeah, thank you. Lorna.
Thank you so much. That's it. I was just going to ask one quick question. If there's anybody listening who thinks, I'd quite like to find out more about the programmes at Health Education England for the CNS training, is there, I know Nate's online as well, is there someone specific they could contact in this area to find out more about that?
Yeah, so what I'll do is I'll get the right email address, but I'll give you the contact in my national cancer team who can give you just a bit of whatever's publicly available, which I skated through in very fast, right? Then give you what's publicly available on the 7 priority professions, precisely what we're doing for AHPs and CNS numbers and so on. So I'll get a link to you of that person, and she's called Sarah Benger, and she's in my national team. So that if you want to have a look at a bit more detail than I've been able to cover, you're most welcome.
Brilliant. Thank you so much. Thank you so much for talking to us.
Okay, well, thank you so much, and good luck, everyone. Keep going.
Thank you so much. Thanks. Well, thank you so much to all our speakers today. I'm sure you agree that they've been brilliant, and I've taken a lot from them, and I hope you all have too. Just a quick reminder, our next webinar is on November the 10th, same time, 1:30 to 2. The focus will be around lung cancer and diagnostics. We've got 2 great speakers lined up for that session. So just a reminder, we will send you a certificate of attendance, and please do complete the feedback form. And thank you so much for coming. Have a good rest of the day. Thanks so much. Bye.